Okay, we're going live very soon.
We are live now. You can go ahead.
Okay. Namaste and good morning. This is Vishnu Sapkoda. I'm the Secretary of American Nepal Medical Foundation. I would like to welcome you all today in this webinar series. The topic of today is managing COVID-19 and multi-system inflammatory syndrome in children. We have distinguished speakers today, Dr. Harris, Professor and Division Chief from Northwestern University. We have Dr. Bora, who is an Associate Professor from Nepalganj Medical College. We have Dr. Krishna Paudel, who is the Director of Kanti Children's Hospital from Kathmandu. Dr. Sumit Agarwal, who is the Consultant Pediatrician from Kathmandu. The session will be moderated by Dr. Sangeeta Basnet, who is an Associate Professor of Pediatrics and our former President of American Nepal Medical Foundation. I would like all the viewers to post their question in Facebook. At the end of the session, we'll discuss your questions. Once again, without further delay, I would like to invite Dr. Sangeeta Basnet to moderate this session, and I'll be helping from the technical aspect throughout the sessions. Dr. Sangeeta Basnet.
Thank you, Dr. Vishnu Sapkota, for the good, nice introduction and taking care of the technical aspect of this. Namaste and good evening. I'm talking from Kathmandu, Nepal, and I would like to go straight into this so we don't lose time. We have 3 speakers, and after that we will have a question answer session. You can post your questions on Facebook, and we will read those questions to our speakers and our panelists. So my first speaker is Dr. Leah Harris. Dr. Harris is the Division Chief of Pediatric Critical Care Medicine and Professor of the Department of Pediatrics at Northwestern University School of Medicine in Chicago. Before she was the division chief, she has been in various leadership positions at Washington University, St. Louis Children's Hospital, Johns Hopkins University, and Vanderbilt. She has received many grants and is an avid researcher and educator. I worked with Leah during my fellowship and beyond in various capacities. Leah knows Nepal indirectly through our conversations and also the elective that her fellows do here, teaching and learning in the PICU at Parton Hospital. I'm really grateful to Leah for accepting the invitation to talk without hesitation today. She's actually one of the best PD intensivists I know. We all know as pediatricians that COVID-19 is not the problem in kids, although Leah will tell us that it is in her institution. It is the post-COVID syndrome also that can be complicated and critical, and I feel that we as physicians here in Nepal don't know a lot about that. And we do need to. Dr. Harris is going to give a brief introduction of COVID in children and then talk about her own experience with children with COVID-19 and multi-system inflammatory syndrome in children. Ladies and gentlemen, Dr. Leah Harris.
Thank you all very, very much. Namaste. Let me pull my slides up and we'll go ahead and get started. Good morning. What I'd like to share with you today is exactly as Dr. Sangeeta Basnet has just described, which is I'm going to run through for you what it is like for us here in the Midwest of the United States to manage children with COVID-19 and MIS-C. And I will share with you in the beginning some of the data from around the world, only to sort of help to format the data that I will share with you from Chicago. And you'll see we're really just a microcosm of what's happening everywhere. Right now, this is the data from last night. You can see that there have been a total of almost 6 million confirmed cases. And in fact, it really is a worldwide pandemic with global deaths that are now getting very close, sadly, to 400,000. If we look at how deadly COVID-19 is, they're still looking, and I share with you the data from China, it becomes important to know that all of the data that we got from Wuhan has in fact remained consistent in every large patient population that's been assessed around the world. There has been one reported case in Chicago of a child under a year of age who died, and yet When that case was sent to the CDC, it has not been validated. So that you can see very clearly, COVID-19 is in and of itself a disease of older children and very much older adults. If we look at the clinical characteristics of COVID-19 in children, you see the following. I'd like to point out that when they looked at all of the pediatric patients at Wuhan Children's Hospital and they did a prevalence study and a testing, they discovered that 171 out of almost 1,400 children were positive. This 12% number becomes very important, and I will share that with you again in a number of slides, that there seems to be something consistent about 12% point prevalence for positive disease among pediatric populations. 41% presented with a febrile illness. As you can see, there were more males than females, 60% to 40%. 16% were asymptomatic. And in fact, when we did a point prevalence study at our own institution, we identified 3 children that were COVID positive that had missed our initial symptom screening that were asymptomatic. And 90% all had some family cluster. So it's very rare to find a child sick with COVID-19 that doesn't have some other family member that has similarly been infected. If we look at the age distribution by symptoms, we see once again much of what you already know, which is that children less than a year are more likely to have symptoms if they are indeed positive. There is a subgroup of children who clearly with comorbidities are worse. This is the data that came out of China, and what they found was that children with leukemia, surgical abnormalities, kidney disease had a higher incidence of needing intensive care support when they were sick with COVID-19. Lymphopenia is present in this population group of 3.5 patients. We have discovered that lymphopenia is a very common finding among our patients with COVID-19. Almost 35% of the patients have some type of abnormality that you can see on chest CT, but I will share with you our chest x-rays are quite dramatic and show these same ground glass opacities. And they discussed one child who was less than 10 months. But overall, the vast majority of children, as you can see, fall into the ages of greater than 1. A significant number are asymptomatic. Many show up with some form of upper respiratory infection, but really it's the pneumonia that goes on to cause the disease phenotype that ends up having these children be admitted to the ICU. When you look at the symptoms of adult versus children, you can once again know that 30% of children have no symptoms, but the symptoms are actually very, very similar. And so initially at our institution, we did symptom screening. We only had available to us a COVID-19 test that had at least a 24-hour turnaround. And so everybody, all staff, all physicians, all nurses, anybody, all cafeteria workers, anybody who walked into the building had to take a survey before they were allowed past the front door, where you were questioned. Did you have a fever or cough, shortness of breath, myalgia, runny nose, sore throat, headache, nausea, vomiting, abdominal pain, or diarrhea? The other symptom that has now been added in the last month is a complete loss of taste or smell. Now that we've moved to having a rapid test and we've been able to acquire enough PPE, everybody is doing universal masking, but still everyone is being asked on a daily basis, both in entering the building and exiting the building. You are asked to complete to find out whether or not you have any of these symptoms, and all the staff have been sent thermometers so that we are checking our temperatures at least twice a day. I share with you the Illinois data. So Northwestern University is in Chicago. We are really smack dab in the middle of the Midwest. And what we see is in fact what I think was reflected in China and has now been shown to be reflected worldwide. One of the questions that Dr. Sangeeta Basnet asked me before we started talking this morning was, how is the disease case rate in Illinois? And what you can see is that really our first cases started around March 16th, and that there was a steady rise, but that we've really very much peaked and are sort of still hanging out at about 2,000 cases a day. And so in COVID parlance, what that means is that we've not really had a peak by sheltering in, but we've just extended the tail, so that we are anticipating we're going to have COVID at this rate well into July. And so by doing so, we have not overwhelmed our healthcare system as we're seen in the pictures of New York and Italy. But it does mean that we've got a lot of very exhausted healthcare workers who have been taking care of critically ill patients since March. If we look specifically in Chicago alone and not the state of Illinois, and this is data from as recently as May 28th, we've had more than 44,000 cases. We've had more than 2,000 deaths. The age distribution is really minimal, less than 0.1% in children under 18 years of age. And in fact, as I will share with you, the two cases that we have are children that are not children. One is 20 and one is 26. But in an effort to help the adult hospitals, we took all children that had been transitioned to adult care but still had a pediatric disease. And we also took all children who were all adults that were cognitively impaired and would function more like children in terms of their management. You can also see that there has been quite a prominent race and ethnic distribution for mortality. And we have many people currently working on looking at different social determinants of health. But there definitely appears to be an unequal distribution of death among brown and black members of our community that we have not yet completely teased out. When I look at specifically just Lurie testing, so only what we've been testing within our children's hospital, we've done more than 5,000 tests, and of those 5,000 tests, we've had 516 positive. This once again turns out to be roughly a 12% positive rate, identical to what they shared with us from the Chinese experience. Of our 516 positive children, only 77 needed to be admitted. The vast majority of these patients were admitted to the intensive care unit because we have been very aggressive in using high flow and the experts from a nursing standpoint in terms of PPE and managing children with COVID, we've now discovered our critical care nurses. We do not have enough negative pressure rooms to be able to support all of these patients. And so in fact, we are supporting patients in single rooms and just being incredibly careful and cohorting all of our COVID patients in similar sort of wings of the ICU. We currently have 4 admitted COVID positive children, all of them in the ICU, and there are 18 children that have been admitted to the floor that are pending results that are not in the intensive care unit. Also important to note that we've tested 500 employees, and of our 500 employees, we've had almost 70 that were positive. The vast majority of these cases have in fact not been patient to staff transmission, but rather have been family members and social reasons how those faculty or employees ended up becoming positive. This is another example of just our COVID testing, and it once again shows you that we have a specimen positive rate of 12. What you can see by looking at the colors is that the dark blue at the bottom represents children less than 1. The green color are children 1 to 4 years of age. Purple are children 5 to 12. The sort of pink is 13 to 17. And the light blue are all of those children that we tested that are above 18 years of age. And so overwhelmingly, this is in our institution, a disease of adolescence. Before I move forward and actually share the cases, I just wanted to spend a very quick moment reviewing the symptoms of how these children are presenting and how this compares to SARS and H1N1, which many of us still remember and see many of these similarities. If you think and you look at the children with COVID-19, and this is a study that was published in The Lancet, they had roughly 3.5%, or rather, they usually average about 8 years of age. Children with SARS were 12 years of age, and children with H1N1 were definitely much younger. All of the children present with some form of fever, although there's so many asymptomatic children, it really only references at 40%. Cough, sore throat, dyspnea remain the primary presenting findings, but for those children that are admitted, pneumonia is overwhelmingly the reason for COVID and for SARS, but was not for H1N1. Fortunately, many of the cases are mild, as I believe you are seeing in Nepal. We have become a pediatric regional center for some of the sickest of the children with COVID. And so some of our numbers are undoubtedly higher than most of the other cities in the state. Patients are presenting with leukopenia, lymphopenia, some with myocardial enzyme elevation, many with elevated transaminases and elevated C-reactive proteins, just generic signs of a super inflammatory systemic response. The two cases that I thought I would share with you, patient one is a young male adult who comes to us with maple syrup urine disease. So that as long as he was on a leucine restricted diet, he did well. He's cognitively normal. He in fact is a manager at a hardware store and very valued by his employees. But in addition to having the maple syrup urine disease, he also had a generalized anxiety disorder. But really what his comorbidity is that we have seen consistently with really 90% of our patients was obesity. So that this was a 100-kilo, 26-year-old young man who first presented to us. The second patient is a 20-year-old young man with Goldenhar syndrome, quite cognitively impaired and developmentally delayed. He came to us 75 kilos. He had a Chiari malformation and had 2 decompressions. He had scoliosis, obstructive sleep apnea, hearing loss, and was G-tube dependent. But these are the two that I thought I would just show you from a comparison because there were some similarities in how they presented and some similarities in how we treated them. So to orient you to the slide, this is patient one, and what I have on top are his days since fever onset, where he was, what treatment was initiated, what his fever curve looked like, what respiratory support we gave him, how much oxygen he was on, whether he needed PEEP, and then any other lab findings that may be of value. So that he first began with a fever greater than 38 degrees Celsius. He was at home for the first 2 days and then came to the emergency department really for the myalgia and the high fever. And he was starting to have some degree of dyspnea. He was seen in the ED and was tested, was COVID positive, but at the end of his assessment in the emergency room, he wasn't requiring oxygen, and the family felt that they would be much more comfortable taking him home. So he actually went home for the next 3 days. And during that time period, his mother and his father also became ill. None of his other family members needed to be hospitalized. And on this 6th day, moving to 7th day, he was still having persistently high fevers, greater than 38.5. He Tmaxed at 40 at one point at home, but it was really his dyspnea that brought him to treatment. He came in, he got started he was on room air being watched, then developed worsening symptoms, was put on low flow nasal cannula of 2 liters. Just to give you some of his labs at that time, because it becomes close to when he was admitted to the ICU, he had a white count of 6, an absolute lymphocyte count of 1,000, so low. His ALT in terms of transaminases was slightly elevated. His C-reactive protein was also slightly elevated at 3.6. Procalcitonin was low. Ferritin was mildly increased as an inflammatory marker. D-dimer was unremarkable. As he started to get worse and he progressed to requiring 30 liters of high flow and 55% oxygen, we targeted and sent off IL-6 levels. And our approach to these patients was to determine early on whether or not they might be tocilizumab sensitive. And we decided only to be using tocilizumab on patients who had elevated IL-6 values. He got started on his tocilizumab moving into his 11th day of illness, his 3rd day in the ICU. And with that, we saw a decrease in his lymphocyte count. His ALT became somewhat better. His inflammatory markers continued to trend up, and his D-dimer also increased. On day 10, when he came to the ICU, this was the chest x-ray that we had. You can see quite impressive bibasilar volume loss, bibasilar opacities with clear areas of parenchymal disease and bronchial cuffing. As he moved into day 11, there was considerably more volume loss. I think it was at that point when he got moved onto high flow that many of us thought he was going to need to be intubated. In fact, this young man never was intubated, remained on high flow, and was subsequently weaned. And I will show you some of his more studies after we review the next patient. Patient number 2, I don't need to orient you as much to the data slide, but was a 20-year-old Golden Har who also had a family that all became sick. His father worked in an adult healthcare facility. His father developed COVID, and was hospitalized. His mother developed COVID, had an arrest, cardiac arrest, had a stroke, hospitalized, and is now out of the hospital but has residual blindness. And then he was admitted. He was admitted directly to the ICU, had a temp of greater than 38.5, was started on high flow, and we weren't sure what he had. And so as part of his rule out, he was put on ceftriaxone because he had a history of aspiration. We decided in this case, based on our infectious disease colleagues' recommendations, and what we've done is we in fact have turned to our infectious disease colleagues and made them our COVID experts and followed their guidelines for recommendation of what type of antibiotics we should be using, or antivirals, or any other treatment. He was originally tried on an azithromycin hydroxychloroquine combination. That did not seem to have any impact on his disease course. He ended up being intubated on his 3rd day in the ICU, requiring PEEPs of 10. His white count also, as you can see, is low. His absolute lymphocyte count is low. He never really had a bump in his transaminases until a little bit later. CRP as an inflammatory marker was elevated. His procalcitonin also was not as impressively elevated. He had a COVID positive count a number of times, and we were just checking his PCR levels to try to get an assessment of his disease intensity. We didn't really find that they correlated very well with that. We kept on really testing him so that we were hoping he would get negative so that we could in fact come off of PPE. But you can see he also had an IL-6 of 35. When that came back, whereas the previous patient had an IL-6 in the 90s, 35 is a elevated but sort of a low value of elevated. That was why ID had recommended the azithromycin and the hydroxychloroquine. But when he still was not getting better, we also started him on docilizumab on day 9 of his fever. You can see that he has much less bibasilar disease in the beginning. But that as his disease progressed and he continued to get worse, he developed more parenchymal disease and more radiographic findings that are consistent with COVID. I just wanted to share quickly some of the data about the hydroxychloroquine and azithromycin combination. This is actually from a pre-publication that was shared with me by one of my infectious disease colleagues. And it was really based on this data that we felt we would go ahead and move forward. The idea was that in patients who had received at least 3 days, that there seemed to be less treatment, less ICU days, and their length of stay was better. But there was really no comparison group, and we recognized that this was not an ideal study to base management on, but yet it was really the only one at the time that we had. The rapidity of how COVID has changed, it's interesting to look back at how you managed a child even a month ago and wonder how we would treat them differently now. And this is another journal pre-proof that also looked prospectively at 11 consecutive patients that had been given hydroxychloroquine and azithromycin. And what we noticed that at the start of treatment, 10 out of 11 had fever and needed oxygen. And within 5 days, 1 patient had died, 2 were transferred, 1 drug was discontinued. but the other 7, in fact, went on to have some improvement. And so we are still using hydroxychloroquine and azithromycin for some of the patients that appear to not be as critically ill. I wanted to talk just a little bit about the docilizumab because it really framed much of our management and why we were measuring IL-6. So if you look here at the classic IL-6 signaling, IL-6 will either interact with the IL-6 receptor. You can have soluble IL-6 that is bound to IL-6 that will interact with the receptor complex, or you can actually have a transpresentation of the receptor also interacting with the complex and then sort of initiating this cytokine cascade. And the docilizumab is an IL-6 inhibitor that acts at this portion of that sort of receptor complex. And that was really the framework for how we started to choose to use this drug. You can see that there are numerous other drugs that have been identified that are all either JAK pathway inhibitors or other STAT3 inhibitors that all are part of the IL-6 cytokine storm. But definitely, as we will talk about a little bit later with the MISC, what really is clear about COVID and this post-COVID viral syndrome is the inflammatory response. And so the inflammatory response in COVID and this cytokine storm appears to be what mediates the disease progression, and it probably is in fact the response to that inflammatory process that is the cause for the MISC that we'll talk about again in a little bit. The side effects of IL-6 interfering with IL-6 are neutropenia, but in truth, there is a lack of large studies, but most of the studies suggest that in a normal host, there really isn't a profound risk for trying to interfere or disrupt IL-6 production. This is data looking at IL-6 and COVID-19, and what I really wanted to focus on is just this graph here looking at IL-6 at first assessment. And what you can see is that in those patients that did not require mechanical ventilation, overwhelmingly they had IL-6 values that were, as you can see, sort of 40 and below. And if you remember, our second patient had a value of 36 and yet clearly falls into this group where he had a lower level of IL-6 but needed mechanical ventilation, and that our other patient, who in fact didn't end up on mechanical ventilation, had an IL-6 value of 96. And so this is really to frame that we think that your IL-6 value can help to distinguish your patient population, but in truth, the 2 examples I showed you, I chose because one had a low IL-6 and went on to require mechanical ventilation, and one had a high IL-6 and in fact did fine with high flow nasal cannula. And this is just the study looking at the docilizumab and COVID-19, also a preprint, and their results were significantly encouraging. And so it was based on these 21 severe cases who did much better, getting doses separated by 12 hours and using fever as the indicator of how long you kept on treating them, that became our guidelines for management and therapy. So here is the clinical course of the first patient, our 26-year-old maple syrup urine disease. So what you can see here is the rest of his course. He gets his tocilizumab on hospital day 12, and then remarkably, he starts to slowly improve. And we were able to wean down in his oxygen, wean down in his flows, quickly get him to low flow nasal cannula and room air. And as he starts to get better, his absolute lymphocyte count starts to come up. His white count starts to come up. We still see an elevation in his transaminases. His CRP drops, and eventually he becomes COVID negative. Interesting to note that his chest x-ray didn't really change remarkably from when he was most ill on day 11 to day 15 when he was really progressing in weaning. So there does appear to be residual radiographic evidence of disease even after the patient is seemingly improving. Patient number 2, who I must share with you, is still in the ICU and still intubated, but not intubated anymore because of his COVID, but rather because of the incredible deconditioning and de-recruitment of his muscle mass. So you hear stories of adults that have lost 50 pounds or 25 kilos. He came to us at 75 kilos and he's now 60 kilos, and his profound muscle wasting is now what's keeping us having to ventilate him. But once again, here you can see that we started the docilizumab, and shortly after starting the docilizumab, we really had a sense that in his case, there weren't clear radiographic changes at all. And so here's an example of somebody getting docilizumab and not getting better. So I really leave you, sadly, with a framework of we're not really sure what direction each patient is going to take, and there are clearly a lot of patient variables, but that overall aggressive respiratory support for those patients that are ill appears to be critically important. This is part of a Palisi-sponsored PICU COVID-19 study. This was the week 4 results. This was a study that was led by Katri Tippo. And I just take one of the shots where she asked 17 different participating centers to let them know what was happening to COVID patients in their ICU. So that, and these are all of the different sites in total that participated. But in the US, as I said, there were 17. But when you look at the world of COVID, what was the likelihood that you would use non-invasive ventilation? And overwhelmingly, people were using non-invasive ventilation, and overwhelmingly, it was their first mode. And what we had discovered as the disease progressed is that we were no longer intubating people early, but rather moving forward and trying to use non-invasive first. Much like your experience, big centers had suspected COVID patients in their units, but in fact, day in and day out, very few of the ICUs had a proven case that they were taking care of. Question 16 of the survey, though, I thought would be interesting to share since I was asked to talk about management, which was what COVID-19 targeted medications does your site plan to use for pediatric patients with suspected or proven COVID? And you can see where red is not using the treatment, gray is unclear. The black to gray, the black is a second line treatment and gold is your first line treatment. So overwhelmingly, first line treatment around the world continues to be chloroquine or hydroxychloroquine, azithromycin. People are using remdesivir, lopinavir and rotenavir, other antivirals. The docilizumab, some are using. Vitamin C has become also very popular, anakinra and IVIG. But you can absolutely see that convalescent plasma is something people are talking about, but very few centers have actually used. And in truth, it's because it's very hard to get. Some of the other drugs that people are using and ones that I did not talk about, remdesivir, chloroquine. I just decided I would show you that here is also some graphs of other drugs that people have been talking about using that have had some success in other viruses, looking at ribavirin, penciclovir, nafamostat, chloroquine. But as you can see, the data is really quite mixed. And so I think we're all going to be walking through this journey together, waiting for a vaccine more than anything. I just wanted one quick word about the convalescent serum, convalescent plasma, only because it's achieved an enormous amount of attention. We had to get IRB approval to be able to do this. We're only allowed to do it for patients over 18 years of age. We've been identified as one of the pediatric sites that can give it. And yet, the one time that we wanted to get it and asked the Red Cross, they weren't able to get it to us for more than 3 days. And by then, the patient seemingly was looking better. So it'll be very interesting to know whether or not this ends up being a valued mode of treatment. Really coming to the end, because what I wanted to share here is that what we really know is in children there are inflammatory responses to viral infections, and you either have a pathogenic dysregulated inflammatory response with robust viral replication, delayed inflammatory moderation, an increase of some of your inflammatory signals and pro-inflammatory agents, and it ends up with acute lung injury and ARDS and death. And that's what we've seen in most of our COVID patients that have been sick. There is the protective regulated inflammation, which is you don't really have viral replication, but you do have an increase in your pro-inflammatory cytokines. And even though it may give you some protective immunity and host survival, this is probably the culprit to what we're now seeing in this syndrome called MISC. Whereas we've had 77 children with COVID-19, we've only had 2 documented cases of MISC. And this is a case of a child that I actually took care of last week, a 9-year-old previously healthy Arabic boy who came to me with 1 week of abdominal pain. He'd been seen in the ED, in fact, 3 days earlier for a rule-out appendicitis, high fevers greater than 38, a lot of abdominal pain. He had stopped eating, vomiting, and diarrhea. He had 2 days history of conjunctivitis. He had 1 day history of dry mouth and lips, but it wasn't red. He had no lymphadenopathy. He was COVID negative, but he came to the ICU because he presented to the ED with profound hypotension. He got 80 cc's per kilo of fluid, and with the 80 cc's per kilo of fluid, his heart rate didn't come down. He came to us with a heart rate, presented with a heart rate of about 130, got started on an epi drip, and there was concern for a cardiac component to his shock. He, while we were waiting for the echo, he had a SED rate come back of 78, a CRP of 34, a pro-B Nancy P of 22,000, a troponin leak of almost 6. Echo was done and showed a stiff LV with decreased function that improved on the epi drip. He had normal coronary arteries. He had elevated D-dimer and fibrinogen, a normal white count. He did have lymphopenia. And after being volume resuscitated, he had a clear S4. So that this is really the child who presents with almost a Kawasaki-like presentation with shock, what we would call Kawasaki in all other descriptions of the disease. And we started him on high flow, 25% just for comfort. He really didn't have any respiratory findings. These are pictures of the child. This is his rash that he had. These are his lips. They were dried and cracked, but really not incredibly impressively red. But he did have a bulbar conjunctivitis. So if you look now at the SARS-CoV-2 or the MISC that we're now talking about, 90% have this conjunctivitis. 54% will have red cracked lips. Most have adenopathy. This child did not. 60% have a rash. And they all present with fever for more than 4 days with a median age of 10. And this young man was 9. What we did is we treated him with IVIG. We gave him a gram per kilo at first because of his heart rate and because of his LV stiffness. And he got much better. And so we didn't give him the 2nd gram that we would have normally done. The next day, he had weaned off his epinephrine. And then within about 12 hours after the 1st gram of IVIG completed, he started to develop hypotension again. So we gave him a 2nd gram of IVIG, never had to go back on his epinephrine drip. And our next line would have been methylprednisolone, but he stayed stable. On his 3rd day, we got back his COVID-19 antibody status was positive. And when we interrogated the family a little bit more, we discovered that his brother, in fact, had been sick 3 weeks earlier with classic COVID signs. So undoubtedly, he had been positive, had mounted a response, and now came to us. So with that, I turn over the platform to the other speakers who will share their experience, and must give great thanks to my infectious disease colleagues who shared with me their slides and data, and really are my frontline partners in taking care of these children. Thank you all very much.
Thank you so much, Leah. That was an amazing presentation. I actually have a few questions, but I think I'm going to just wait until all the speakers are done so that we don't. So I'm going to introduce our next speaker, Dr. Roma Bora. She's a pediatric associate professor from Nepalganj Medical College. Dr. Bora is one of the frontline physicians in Nepal. Because Nepalganj is one of the areas that has been hard hit, and she has graciously accepted our invitation to talk about her experience. What she has seen in Nepalganj regarding the children admitted there. We know none of the patients were ill, but we are very curious about how they were managed for days in the hospital after their PCR assays came back positive. So Dr. Bora, I give you the stage. Are we stuck? Kiva. Hello?
Yeah, thank you. Namaste, everyone. Thank you for inviting me to share my experience on COVID-19 in children at Nepalganj. So, next slide, please.
I think, is Dr. Bora still on?
Yeah.
Go ahead.
So this is regarding our cases. We had a total of 1,212 cases till date, out of which 1,000 patients are there in isolation and 206 have been discharged, and there have been 6 deaths. So it constitutes that 82.5% are there in isolation and 17% patients have been discharged, and mortality is 0.5%. Now, distribution of patients according to province. Next slide, please. Next slide, please.
I think he's gone to the next slide, but it's delayed for you.
So the previous slide is showing the provincial distribution of cases in Nepal. So our province, province number 5, is at second number in terms of number of cases. And first COVID-19 case in Nepal was confirmed on 23rd of January 2020. And first death due to COVID-19 in Nepal was documented on May 16, 2020. And the first pediatric COVID-19 patient in Nepal was reported on 23rd of April. Now coming on to the pediatric patients. Next slide, please. So as per age groups, in the reported yet in pediatric population. And here in our district, in our isolation hospital, we are having 3 children and they're all well, they are all asymptomatic and they have been diagnosed on contact tracing. And all these 3 children have been discharged. Now we are having 1 child in isolation hospital whose mother is positive, and that's a 11 months old child, but the child is negative. So I'll tell about our cases, which I have seen here in our isolation hospital. So the first patient was a 7 years female child. She was admitted in isolation hospital on 3rd of May 2020, and she was diagnosed by contact tracing. She was not having any symptoms of the disease, and she was asymptomatic throughout her stay in the isolation hospital. And she was kept there in the hospital for 2 weeks, and then 2 RT-PCR were done 24 hours apart, and both were negative. Then she was discharged. Similarly, we had a 9 years male child and one more 11 years female child, and they also had similar presentations, meaning by they were also asymptomatic. So we have been lucky enough in not getting any like symptomatic patients or any severe patients or complications of COVID-19 till now. But we have to be prepared to face MISC in future, because we may get further cases of MISC as a number of cases will increase, because till now we are having very less patients. So in future we may get MISC patients, so we need to be prepared and we need to be aware for this condition. And I won't go in details of MISC, as Professor Harris has very well explained regarding on the MISC and everything. So I'll be just telling.
Roma, are you done?
Yes, ma'am, please.
Okay.
So I won't go in details of MISC, because Professor Harris has very well explained regarding MISC. I'll be talking about my experience in dealing with the COVID-19 patients here in Nepalganj. So the only good news about COVID-19 pandemic seems to be that children are either asymptomatic or having very mild symptoms. And in Nepal, till now, we are having all the children who are asymptomatic, and they have been all diagnosed by contact tracing only. Not even a single child is diagnosed on the basis of some symptoms or has come to hospital for some complaints. So we had total 5 children, out of which 3 were positive and were admitted in the isolation hospital, and 2 were suspected to be COVID-19 as their parents were positive, and the report of those children came out to be negative. So it's really a very challenging position for us, especially in managing children, because we are having 11 months child whose mother is positive and the child is negative. So on one hand, we are having a dilemma that whether to keep this child in isolation with mother or not. On other hand, family is also not allowing the child to keep separate from the parents. Even child can also not live without her mother in the isolation. So it's really a very challenging condition for us. And in the very beginning, like we were not able to manage baby foods, and there were no toys for the children, and it was very difficult for children to be there in that confined space of ward for a prolonged period of 17, 18 days. Now gradually we have managed regarding the baby food and all those toys. So now it has become little bit baby friendly. And we also faced many challenges, like in the beginning when we started isolation hospital in Khajura, then some people left that area considering that they will be infected, but gradually people are being used to, and because they have seen that people who have not left that area are well, they're not having any symptoms, they're not infected, so people are now getting used to, and they're not that much fearful. I'll share one story. Like our medical officer, one of our medical officer who went to isolation hospital, he was on duty and he went inside the ward, and one child came and just held him. So he was very much afraid, even though he was wearing the full PPE, he was using mask N95, and he was using visor and face shield, everything. So this was the fear, like in the beginning, and it was quite challenging to counsel everyone, like all the health staffs and medical officers and everybody. But now everybody is getting used to that, they are not getting infected if they are using proper precautions. uh, we are facing one challenge in terms of feeding of small children, like they are with their mothers. So it's really difficult in our context to teach these mothers that they should practice all the proper hygienic practices, hand hygiene and everything, and they should cover their mouth all the time by using face mask. So these type of challenges we are facing in our context.
Thank you very much, Dr. Bora, Roma. Thank you so much for working in the front line. We are truly very grateful that you guys are extremely brave and taking care of the kids over there. We will save the question answers for later. I now want to introduce Dr. Krishna Prasad Paudel, who is the Director and Chief Consultant Pediatrician of Kanti Children's Hospital in Kathmandu, Nepal. As the director of the only child's hospital in Nepal, who better to talk about the challenges we face in this country managing the health and disease of the little ones? After hearing Dr. Harris's talk and the sophistication of management in the US, and Dr. Roma's talk about how the challenges that she's facing, I feel like Dr. Paudel's talk will show us the reality of managing children in Nepal and how much more we as pediatricians and physicians need to do as the child's advocate in Nepal to bring better healthcare services to the kids. Like I have said to him, this important topic is a talk in itself and warrants a full hour, but we will hear a very brief preview today. Without further ado, Dr. Krishna Prasad Paudel, I present the stage to you.
Thank you, Dr. Bosnet, and good evening, namaste, and good morning to all my colleagues in the US. Basically, as we already discussed and is highlighted by Dr. Bosnet, we need a separate session on COVID and Nepali children, or the like specifically designated for Nepali children. And rather than just about Kanti, I'll be talking about the current position of the Nepali children and what could be the comorbidities and the risk to Nepali children. Dr. Vishnu, can I have the next slide, please? So we already knew about the US and China data, but what I need to show to you is as per the yesterday's data, we had 1,212 positive cases in Nepal. Today, the data has come to 1,401. And under 10 or below 10 years were 37 cases, relatively higher than what we saw in one city of China. And even 11 to 20 years, there were 254. That means almost a quarter of positive cases were below 20 years. And it might be surprising to many colleagues, especially in US, that our pediatric population in the hospital criteria is 14 years in Kanti Children's Hospital, which is not consistent. And we all pediatricians are fighting for child and pediatric, at least under 18 as a pediatric age group. So if we take under 18, so we do have nearly a quarter population which is positive with COVID, and thankfully all of them were asymptomatic and well, and no mortality in this age group as of now in Nepal. Next slide, please. Dr. Vishnu, yeah. So this I have already mentioned. This was the report of Health Emergency Operations Center presented yesterday, and this highlights the age distribution in Nepalese context. Next one. Next, please. Okay, maybe we might have to go. Okay, this is a good one. So if we look at this population pyramid in Nepal, so people who are interested in knowing about the morbidity, mortality, and the disease trend in our country, we need to understand that nearly 40%, roughly it comes to 38% of population is below 19 years in Nepal. So we will be dealing nearly half of the population, but the current health structure is I don't know how friendly with the children in our country. We didn't have a number of pediatricians which are adequate, roughly around 300 pediatricians across the country, of which nearly half of them are in Kathmandu or in major cities. So it's very challenging to have a pediatric service in different parts of the country. Next one, please. To add further, you can just see there are two pictures. It might be a bit crowding of the slide here, but we can observe that the immunization coverage of children in Nepal might be good in terms of the BCG coverage, which is almost 94% here, but that's been like declining in recent few years. And you can also see the coverage of the other antigens, for example, PCV 10, which is roughly around 70%. And the second dose of measles is even lower, 67% around. So there are like risks that we might have more pneumonia, more measles related death, and we already have noticed few measles outbreaks in our country. And same slide also showed the nutritional status of children. So we are the country with not only with the highest mortality of children, infant, under 5 children, infant or neonatal age group, but also we had highest rate of childhood anemia, stunting, as well as wasting. So on top of this, if these children do have COVID, we are like, we are more apprehensive that they might have more complications in these children. And a common, if this might be interesting to all my international colleagues or my colleagues who stay in US, we do have same challenges which is like lack of basic healthcare, poverty, the challenge with literacy, especially health literacy, and majority of our deaths are preventable deaths as of now. And we are still struggling with the 5 major killers: pneumonia and diarrhea, where most of the COVID symptoms do overlap, and measles and malnutrition are another similar, like, the major killers. And same with the newborns, also prematurity, low birth weight are the perinatal asphyxia as well as infections are the cause of death, and these majority are still preventable. So currently government have designated hospitals as COVID hospital, for example Patna Hospital in Kathmandu Valley and the Armed Forces Hospital as a unified hospital, and they have identified hub and satellite hospital. It might be surprising, but Kanti Children's Hospital is working as a satellite hospital as of now. As I already mentioned, there is acute, like surges of pediatricians across the country, majority being in major cities only, and pediatric ward. And my concern is because pediatric intensive care units, we don't have adequate beds all across the country. Only the tertiary level hospitals and medical colleges do have few pediatric intensive care beds, and availability of pediatric ventilators is also challenging. In Kanti, we have prepared isolation levels 1, 2, and 3. Basically, as of now, we'll be keeping symptomatic, PCR positive, or if needed, RDT positive currently in the isolation ward. And level 2 and level 3. Level 2 is for those needing oxygen, level 3 for those needing ventilation. And recently, we had one 9-month-old child with IgM positive for COVID, this SARS. Luckily the child did well with our 2 days of ventilation, out of ventilator now, and PCR also came negative. We do have RDT, but we didn't have PCR as of now, and it takes almost about 36 to 48 hours to have a PCR report. That's why our isolation is always loaded, waiting for PCR report. And we are following regarding diet, immunization, and all these things. We are following International Pediatric Association guidelines, World Health Organization guidelines, as well as Ministry of Health and Population guidelines. And a lot of positions papers are there as of now. But in the field level, there are still a lot of confusions and challenges to manage. For example, a case of retinoblastoma who was a grade 4 retinoblastoma, came sick from one of the red zone district in Nepal. She expired. We're waiting for PCR report, and this is like, this is what is happening here and infection prevention practices, as Dr. Bora highlighted. It's very challenging with especially with the visitors, and keeping control of the visitors is also a big challenge for us. Maintaining hygienic practices, the way the number of people stay with the children in hospital is also a challenge. That's all from me as of now, but I hope we'll have another session talking about the challenges, opportunities, and what we are doing in our setting to deal with this COVID crisis or COVID pandemic in our country. Thank you.
Thank you very much, Dr. Paudel. Now I'm going to open the floor for question answers, and I have a few questions over here, and I'm going to ask the panelists and the speakers to answer these questions as I read them. Reshma Shrestha has asked, She read an article where oropharyngeal swab of neonates came to be negative, but anal swab to be positive. Is it necessary to do both? Leah, do you have any ideas of that, about anal swab being positive, but oropharyngeal swab in neonates being negative? She read an article.
So for diagnosis, we are only doing nasopharyngeal swabs. There has been data looking at oropharyngeal versus nasopharyngeal with some mixed results. And I think some of it has more to do with testing and the different methods of testing. I think that people have done absolutely, not so much anal swabs, but we know that there is shedding in stool of neonates. And so I don't know that any, I don't know about using anal swabs as a form of diagnosing, but it's clear that children can absolutely shed the COVID virus, and it can be shed in stool.
Thanks, Leah. My husband, Dr. Jana Koirala, who's an ID, is just next to me right here, and he's saying that there's not much evidence to do anal swabs as of yet, like you correctly said. There is another question from Rogina Paudel. Dr. Harris, for mechanically ventilated patient, what is the initial ventilator settings being used? Thank you. That's her question.
So there was a lot of discussion early on that we should be treating these children, these adults, also like ARDS. And I think that some of the work that came out from Gattinoni in Italy really helped to reveal that there are two phenotypes of disease. And so you really need to know whether you're dealing with somebody that has parenchymal injury that is going to be PEEP sensitive. Many of them, in fact, are not. And so that there is no magic level that you need to start with. I will say that we have, for almost all of the patients that we've intubated, started them off with a PEEP of 10 or higher if they're on a higher FiO2. So those patients that by the time we are preparing them for intubation are on high flow nasal cannula 100% with marginal oxygenation status, then those are the ones that we have deemed to be more PEEP responsive. I think that part of the problem that we're having with some of our patients is that COVID is not only a parenchymal lung disease and an alveolar secretion burden disease, but there's definitely a component of microangiopathy and thrombotic disease that's impacting small vessels, so that you can have patients that are silently hypoxic. They actually don't feel dyspneic because they don't have alveolar disease. What they actually have is VQ mismatch because they don't have vessels that are there. So for those patients, putting them on high PEEP doesn't help because in fact it can inhibit blood flow. So there's sadly no magic answer. We have to look at everybody, but for patients who are hypoxic, we've been starting off with PEEPs of 10 if we have to.
Are you proning kids also?
There's a subgroup of children that we're proning, and if you are, we will prone them on high flow. And if we prone them on high flow and they appear to improve, then we don't end up having to need to ventilate them. If you are intubated, we will absolutely try proning, and it's been effective in a small number of our patients, certainly not the sort of panacea that has been described in adults.
Oh, really? There is another question by Raju Kafle. He's asking, we have a confusion about suspicion criteria of COVID-19 when they do not have contact history, but present with bad chest X-ray resembling ARDS. We have limited tests in the area, so whether go for a test or send to isolation, or just go by contact history and decide for tests. Leah, would you be comfortable, or should I ask any? Yeah, go ahead.
I'm happy to jump in, and I'm happy to share. I think that we are dealing, I was so struck by Dr. Roma's description of having to wrestle even with the issues of feeding children and having somebody to take care of the child and not having visitors and how to manage that, because we actually stopped visitors. No family could come in. And it was very unpopular in the beginning. And only now are we allowing a parent at the bedside. And if you have a COVID positive child, you're only allowed to come in and then you can't leave the room. We're not, so that we've gotten rid of visitors. So we definitely are dealing with very different issues. But if somebody comes in with a clinical history, but without a contact history, we still treat them as if they have the disease, and we would isolate and we would test. And I think it's because we know that there are so many asymptomatic carriers. The patient I present, my 9-year-old who had MISC, the family did not remember that the sibling had been sick 3 weeks earlier. But that clearly is where he got his infection. They were clearly co-ill at the same time. And the only way we now know that this young man is an MISC is because he's got COVID antibodies from his exposure 3 weeks earlier and now has the inflammatory stimulus. So not having a contact history doesn't help you. So we're doing universal masking because we don't trust contact history. It's only a value if the contact was positive. And as a result, if you come in with symptoms that are suspicious, we isolate until we can prove you're not.
And like you said, even if the test is negative, and if you have a clinical suspicion, please just isolate until you can be absolutely sure.
It's really the risk for the healthcare provider, because if you don't isolate, then you have the potential to infect 2 nurses, a respiratory therapist, 3 physicians, and then you've lost your team.
Right. There's another question from Reshma Shrestha. She asks, has there been any case needing emergency surgery? What about negative pressure operating room and post-op or SICU, surgical ICU bed?
Maybe.
Go ahead, Dr.
Sally?
Okay, Krishna, go ahead. Who is it?
We do have negative pressure. We do have negative pressure rooms in our central intensive care unit. And we even kept a case initially for isolation there also, suspected case. And we do have separate surgical ICU. And as per the current protocol, we are not doing any elective surgery for COVID cases. Only for life-threatening cases, we will be doing surgery, but there are also logistic challenges because we do have a single operation theater for the kids. And the current, like the earlier septic operation theater is not in operation currently. So we do have challenge. If we have a COVID positive case in a hospital, it will be a challenge for us to operate on other kids because we are a general hospital as of now. It's not a totally designated hospital as of now. But we do have facilities for surgical intensive care as well as the negative pressure rooms.
Did you want to say something?
I will say that, Sangeeta, what we've had,
yeah, go ahead. Yeah.
we have actually had a handful of emergency surgeries that had to be done on children, either before we could get back COVID results, because in the very beginning, we only had a 24-hour turnaround. And for those, the entire OR crew wore PAPRs, and because we don't have negative pressure ORs. And so everybody wore PAPRs, the anesthesiologists, all of the OR nurses, all of the physicians, and they were able to have the surgery and have a good outcome. But the change to a rapid test has changed our practice so that we can do a rapid and know. There have still been a handful of cases that have had to go to the OR or interventional radiology or some other procedure. When you do it, everybody just wears extra PPE.
So this rapid test you're talking is rapid PCR.
It's a rapid PCR and we get it back in about 45 minutes.
Wow. So there is another question. Sabina Shah Pahari, who is my very close friend, by the way, asks, what medications did the ventilated child require? I know you said a little bit, but can you tell us? I had a question that I want to piggyback on that. Do you still use hydroxychloroquine? Because WHO right now says no. And I guess kids, do kids get the QT, prolonged QT and all that kind of stuff? That's why we use it in kids, because there's an uproar in Nepal right now that don't use the hydroxychloroquine.
So we're not using it now, ever since the WHO recommendations and the two studies that have come out, the French study in particular. So that's why I said I sort of laugh at how we presented and managed some of our patients even a month ago. We absolutely are seeing prolonged QT, and part of it is that for those intubated children, we have transitioned them from narcotic infusions to keep them comfortable, and frequently we'll use methadone. A lot of these children have other comorbidities. So the young gentleman that I presented with the golden heart who had behavior issues was on Seroquel. So we're finding that we actually have patients with polypharmacy that do give them long QT to start with. And in addition, so many of our patients are obese and have underlying OSA, and so also have evidence of cardiac strain even before they get sick. So managing them with serial ECGs has become really important. And so we have stopped the hydroxychloroquine.
Do you use remdesivir? I know you showed a few plasma.
We've been given, so you have to get IRB approval to use the remdesivir, much like the convalescent serum, only in patients over 18 years. I do not believe we've even used it yet. I think all of our patients have been treated with the tocilizumab right now.
Okay. Let's see. There's one question that says about can ivermectin decrease viral load within 48 hours? I'm not sure you've used ivermectin, Leah. And Janak, my husband, says there's no evidence. So anyone on the panel knows anything about ivermectin? So it's still in clinical trial, he says, so we have to wait for that. There is one question that says, do you suggest to test accompanying visitors with PCR or RDT? I want to ask Leah first what you suggest and then go to Dr. Paudel.
We haven't been testing visitors because we aren't letting visitors in. We all of our supplies are so limited. And so, I mean, it's only been in the last couple of weeks that we've been able to do 3D production for the nasopharyngeal swabs. We started to run out of swabs. And so we just don't have the media to be testing family and visitors. But that said, there is a subgroup where we are testing family. We have children on active transplant lists. And for the active transplant children, the living donors all get tested, and their families also are getting tested just to get a better sense of what the potential exposure is for these children post-transplant.
Dr. Paudel, what did you do with that patient's family?
Actually, that's quite confusing for us also. We have kept like for newborns, we'll be testing mothers. That's mandatory, but case by case, the situation might differ. For example, we had today also, as I mentioned you, retinoblastoma case, which expired because we need to keep the parents till PCR report of this child comes to us. So we did PCR to the parents and that came to be negative. And a few days earlier, we had a seemingly looking like a COVID case presenting in respiratory distress in emergency room who expired on presentation to hospital. So we did RDT of other accompanying parents also. And luckily the PCR of this patient also turned out to be negative later. But like it's basically case by case basis. And for surgery, like small kids, we had one case of tracheoesophageal fistula today. And again, the mother was tested for newborn. So it's case by case, and some of our colleagues are so apprehensive because we could not control the visitors coming to our hospital, in spite of telling that only one parent, for example, mother or father, will be allowed, but it's not being so practical here. So we might have to do on that situation. But again, the supplies and logistics are also a challenge to us.
So there's another question, Leah, if you want to answer this. Is MISC limited to only pediatric age group? as of now?
No, I see Dr. Agarwal also getting ready to answer, so feel free. I think it's raised a lot of attention because people are worried about children, but no one is immune from having a post-inflammatory potential response.
Dr. Agarwal, do you want to answer, pitch in? You'll have to unmute yourself.
Thank you. I think not only adults, MISC has been seen in adult population also. There are case reports in literature, so it's not just confined to children.
Okay, thank you so much. There is one question. Any long-term complications of COVID survived kids? I guess we don't know yet. Are there any long-term complications that we know?
Our first cases started in March, and so I don't know that we're going to know what long-term means for quite some time. I can say though that the few that we've had, and especially the one that I share with you that's still in the ICU and still on a ventilator, who's so profoundly deconditioned, I anticipate that he will have chronic lung disease and perhaps even chronic muscle weakness.
Leah, for you again, Dr. Harris, this is by Bashant Rai. Dr. Harris, which is more common presentation, typical or atypical Kawasaki, and how early can it present as COVID? Number two, this is probably for the Nepali panel, as we face with dengue and scrub typhus now, how common is cross-reactivity with COVID? So the first question is, what type of Kawasaki, typical, atypical? I guess both.
If I had Anne Rowley, our Kawasaki expert, in the room with me, she would tell you that Kawasaki's is much more common than MISC. But I think in truth, we don't know the extent yet of what we're going to see. And as a regional pediatric hospital, we still see 3 to 4 Kawasaki's a month. But we're only now starting to see the MISCs. So I think you just have to be vigilant in the case presentations. And if these children, and many of these children will be in fact COVID negative. And if they never have COVID antibodies, then it will be an intellectual conundrum as to whether or not to label them as Kawasaki's or to label them as MISC, except to say that the majority of the MISC children that we have read about and the 2 that we have seen had extensive cardiac involvement, elevated troponins and BNPs from the beginning. And that's not typical of the Kawasaki's. Even the children who go on to have coronary artery disease, they may end up with markers of cardiovascular disease involvement, but it's not usually in the beginning of their course.
Thanks. Dr. Portal, do you think you can answer this, or are we still waiting for
I'll hand over to Dr. Sumit, because it's again.
Let me ask the question again. Are we facing dengue and scrub typhus? Because we are facing that right now. How common is cross-reactivity with COVID?
I think there has been demonstrable cross-reactivity with JE, but I'm not sure whether it's cross-reactive with scrub typhus. I don't think it's cross-reactive with scrub typhus. I'm not sure about dengue. But
okay.
Cross-reactivity with JE antigen has been demonstrated.
Okay. I think that is most of our questions right now. The only thing that my friend Sabina says that apparently single dose ivermectin helps. We'll probably have to wait for more studies on that. But that is the end of the question answer session that I have. Maximum number of people that I saw was about 125 to 130 that were watching from all over the world. My residents have been watching from the United States. I see. And so it's been an amazing session. Any last words? Since you were on, Dr. Agrawal, do you want to say just a few words, last words? Go
It
ahead.
was a very
Anything that
good. It was a very good talk. Very informative, Dr. Harris. I'd like to thank us so much for sharing our experiences. That would definitely help us in better care of our children. And I think we are at this point of time, we are not going to definitely see MISC patients because the cases are still on the rise. And once 2 to 3 weeks after we have reached the peak cases in the country, then we'll see MISC cases rising in our country. So we'll have to have a high index of suspicion in diagnosing cases of MISC in patients who have had COVID-19. And RDT will be useful then rather than at this point of time in diagnosing MISC in patients. Thank you.
I think that's a very good point, Dr. Agrawal. Dr. Paurel, would you like to say any last words?
I'd like to thank American Nepal Medical Foundation, yourself, my colleagues, Dr. Vishnu, as well as Dr. Lynn Harris. I think we need another session focused on Nepal, maybe longer.
Yes, absolutely. We'll do that.
And I could see Dr. Khadka also. I hope he will also consider keeping another session. Dr. Binod, I request him also.
Sure.
Dr.
Yeah.
Roma, do you have any last words to say? Since you're in the front line, you have to unmute yourself.
Yeah, it was really a very enriching session, and the talk of Professor Harris will be very useful for us because we may also have some cases after some time of MISC, and of course, Dr. Krishna's talk was also very good on behalf of on these public health measures. So in next talk on our Nepalese situation, I hope we'll join together and we'll share our experiences. So thank you.
Thank you. Dr. Harris, Leah, would you like to say anything? You have to unmute yourself.
Just thank you so much for inviting me. And just be safe. Be safe and stay well. You are the front lines and you are going to make a difference. Just take care of each other.
Before I go to my ANMF team for last words, let me just also comment that people have been watching from all over Nepal. Solukhumbu, which is like in the mountain areas, from Dharan, the east of Nepal. I mean, all over Nepal, pediatricians and clinicians and probably even lay people have been watching. This has been a very informative. Before I hand over to ANMF team for the last words, I just want to say one thing. We were thinking about creating a registry for COVID and post-COVID patients. Like Dr. Agrawal said, we will be seeing post-COVID patients, maybe as a team, as a group of pediatricians with various expertise, we can help around the nation. So I will probably talk to you guys soon about creating that so we can help our colleagues around the nation. With that, Binod, our Vice President, do you have anything to say?
Sure.
Dr. Khadka?
Yeah, thank you very much, team. First of all, I want to thank everybody from Dr. Harris from Chicago to all the team from Nepal. So I want to say, as Dr. Harris said, stay safe, take care. We are very fortunate to have your time and expertise here. And just want to share, like we're just seeing on Facebook Live here. So you have reached like 3,200 people right now. So just within an hour, there is like 3,200 people seeing from all over the world. As Dr. Sangeeta said as well, basically they're like people from remote part of Nepal to US to throughout the world. So we have been a global village. We are very, very honored to give this platform. ANMF is like more voluntary on platform where like-minded people, we all want to come together, share our expertise and bring that take that fear away, so we are on the front line, but at the same time share our experience, expertise, and take that fear away and combat with the disease. So working on front line, I work as a hospital internal medicine as a program director on my one of the hospital, and from there we have the same type of challenges as well. Like every time I go to work, like we have two to three patients under my list, and then about 40-50 patients under our overall list. So last time when we shared the same thing with Nepal team, it was great to know their perspective, great to know how things are going here, and those exchanges of ideas give us skill and strength to work better. So uh, from ANMF team, I want to thank each one of you for the valuable time, and at the same time I want to thank all the viewers here, like 3200 plus within an hour, and they usually reach within 10,000 plus within a day. So we want to thank you for taking that valuable time, watching from all over the world, and helping spread the knowledge and fight this COVID. So much appreciated. Thank you very much, and namaste to all.
Dr.
Thanks,
Basnet,
Binod.
yes,
I do want our where is Bishnu? Bishnu?
yeah.
Oh,
Hi,
there you are. Can you,
namaste, Doctor. First of all,
before you say, before that, I just want to thank you. I mean, you have been so amazing at conducting this, and a true professional. Okay, go ahead. Now your
okay,
turn.
thank you, Sangeeta Di, for that, for your kind words. I would like
Thank you.
to ask Dr. Bhupendra Basnet, ANMF President, to say a few words. Dr. Basnet, do you have anything to say?
Thank you, Dr. Binod. It was excellent presentation, interactive discussion. Thank you, all the speaker, panelists, especially Professor Harris. We'll be in next week also. We are doing regularly, and each Saturday, we'll be in next Saturday, we'll meet. We'll let you know that all audience, our topic, we'll let you know later. Thank you, everyone.
Yeah, Dr. Podel, if you have a topic you want to discuss, if you have a panel of speakers, please email us, and we'll definitely arrange a session for you. And once again, I would like to thank you all on behalf of American Nepal Medical Foundations. Stay safe. Have a good morning from USA, and have a good night in Nepal. So I'm exiting the live right now.
Thank you.
Thank you.
Thank you.
Namaste.